and priority setting. So I'm going to start briefly with a review of the National Academy of Medicine or Institute of Medicine report goals. There are 8 recommendations they made in their report. And these are paraphrased, but I think they roughly get at what the IOM was talking about in their sort of more technically worded recommendations. The first is to make nurses, allied health professionals, and patients part of the diagnostic team. So I think that's a critical goal and one that we're obviously taking action on. The second was to teach clinical reasoning and cognitive errors. Again, our education core is tackling many of these issues. Leveraging health IT to improve diagnosis. And one of the things that we need to think about a little bit, we don't have a technology core, but we do have an analytics core and a methods core. We have to sort of figure out who's pushing the technology piece of this forward, or are we doing it in a distributed way across our various units and entities. The fourth is to monitor diagnostic performance and give feedback. And it's clear that we're doing projects along these lines. One of our key initial signature initiatives for the center is this MOORE dashboard project, where we're going to be essentially working on ways to at least give institutions feedback on their diagnostic performance. But to think systematically, though, about how we're going to get down to the level of individual clinician feedback at some point, and how is that going to happen, and how are we going to make it a reality that works from an operational standpoint. The fifth is to change culture to avoid blame and shame, and we've got great institutional leadership buy-in for the center and its mission all the way to the highest levels, including the dean, who's been stumping for this issue for quite some time. And but we need to think about whether we need to have specialized culture surveys that relate to diagnosis, or whether we need to take existing culture surveys and say, okay, look, let's think about, point people's attention in a different place. One of the ideas that was discussed at the National Quality Forum was, should we have a whole separate survey for diagnostic safety culture, or should we take the existing safety culture survey and give people an instruction at the top that says, do this once thinking about a therapeutic scenario in your unit, and the second thinking about a diagnostic scenario in your unit. Really sort of asking the question about how we're doing in terms of a diagnostic culture. The sixth is to encourage open reporting and liability reform. And reporting obviously is something that we're already encouraging. We've got our Teams core has put out there a new icon in the HERO, the Hospital Event Reporting Online system. And as a function of that, we've already started to see a marked increase in the submissions of reports of diagnostic errors. So even just kind of getting it on people's radar screen is bringing some of these things out to the foreground. But then we have to start talking about, well, are root cause analysis groups equipped to do an RCA for a diagnostic issue? And how does that differ from an RCA for a therapeutic issue? What are we doing to take those results and make them actionable? Is it just flowing them into the same pathway, or do we need a special pathway for how we deal with the things that derive from the analysis of these event reports? The seventh is to use payment reform to promote diagnosis. We have a great luxury here in the state of Maryland that we are under a globally budgeted hospital healthcare system now. And what that's done, if nothing else, is it's opened up a space to innovate that was not there before in diagnosis because of this potential of improving diagnosis to both improve quality and decrease costs. It opens up business opportunities that were heretofore closed to us. When I took these ideas about improving diagnosis of stroke patients in the emergency department before the global budgeting to the business office, they said, well, that sounds like a nice safety project, but how many CTs are we not going to do, and how many MRIs are we not going to do, and how many admissions are we not going to do? They weren't so excited. But then after the global budgeting, I went and presented them again. They asked me the same questions, just with a little different tone in their voice. They're like, how many CTs are we not going to do, and how many MRIs are we not going to do, and how many admissions are we not going to do? So the excitement level changes, and ultimately payment's going to be a critical lever in this at a national level, but we have to be able to show that the lever is a driving force for better diagnosis so that we can get that implemented at a national level. So we're going to have to do work in that space too. And ultimately, coordinated increased research funding. we've been down on the Hill. I've been down, visited with 24 legislators, staffers, offices over the course of the last 6 months. And in that time, what we've seen is a tremendous receptivity to this issue, something nobody had heard about or knew about. It's now rising on people's radar screens. We've got Chuck Schumer having a private dinner with one of our donors, that's funding the effort in his home, talking about diagnostic errors. He's going to be talking at the Rory Staunton Foundation at their meeting about sepsis misdiagnosis. So we've got this issue starting to be socialized among both Democrats and Republicans. It's a nonpartisan issue, and people are moving towards leveraging the kind of model that we've developed here, which is this incredible center that's become an aggregating source for great human capital, as you can see in the room. Teams of people who are committed to this idea, who are rallying around the cause, and that idea then exporting it all around the country through centers of excellence is a critical issue. So those are the National Academy's goals. What are the center's goals? And again, these are things that we have the opportunity to modify as we go forward, but I want to make sure that I just put them each out there. So we have 10 goals that are long-range goals. One is to raise awareness. The second is to engage partners. The third is to prioritize problems. The fourth, to identify causes. The fifth, to implement solutions. The sixth, to measure impact. The seventh, to develop new methods. The eighth, to build capacity. The ninth, to create networks. And the 10th, to influence policy. And as you may have gathered from the discussion that's happened already just this morning in the last couple of hours, that we have activity moving on all of these fronts, not evenly and not equally, but certainly we're moving towards these goals, and we have to think a little bit about which of these goals we're going to prioritize as first steps. This is a conversation that's happening not just with us as a new center, but even nationally, as a big national movement. What are the next steps to move forward? There are a million things that we could do. Which of those things are we going to focus our attention on as we go forward? So with that preamble, Manny, are you going to run a poll? You're going to tell... And pick the 3 that you think are the most critical for us to move forward at this stage of our nascent life as the center. Which 3 do you think are critically important? Sure, you can be self-serving if you want. There's no prohibition against being self-serving. It's like gambling in a horse race. Like, go number 4. All right, so it's fascinating, right? So we got at least 15 people responded to that question. I'm going to turn it over to Amy and Liza to sort of moderate the rest of the conversation on this point for this first piece of the dialogue, and this is a nice place for us to start.